I'd now like to introduce Dr. Alan Kliger. Dr. Kliger is currently a clinical professor of medicine at the Yale School of Medicine and serves as the chair of the American Society of Nephrology's Excellence in Patient Care Advisory Committee. Dr. Kliger.
Glenda, thanks. And wow, what great issues and questions for patients you raise. We need to pay attention to that. I want to spend a few minutes talking about how the pandemic uncovered disparities of care that we need to pay attention to, and sort of a high-level view of what we learned over the last 3 years of the pandemic. Antonio Guterres very nicely said back in 2020, COVID-19 is exposing fallacies and falsehoods. The lie that free markets can deliver healthcare for all, the delusion that we live in a post-racist world, the myth that we're all in the same boat, because while we're all floating on the same sea, it's clear that some are in super yachts while others are clinging to drifting debris. Here are some of the facts. This slide shows the numbers of patients undergoing maintenance dialysis between 2017 and 2021. The high line, that black line, shows dialysis patients, and the blue line shows kidney transplant patients. You can see that there was a sudden change early in 2020 in the number of patients undergoing chronic maintenance dialysis. For the first time in 50 years, the numbers fell rather than were rising gradually. A lesser but clear effect, likewise, was seen in the transplant population. And here, this slide looks at, in 2020, pandemic deaths in dialysis patients. The left-hand panel looks at the years 2013 through 2019 together at the bottom, and then how different 2020 looked in the number of deaths per number of patients at risk, that is, numbers of patients on the dialysis. And you can see in 2020 a marked shift upward in the numbers of deaths. On the right-hand panel, those same data are stratified by race. And the patients of the Black race are shown in the solid lines, and patients of the white race are shown in the dotted lines. For all of the years before 2020, there were similar outcomes, with Black patients having better mortality than whites. But you can see in the year 2020 a marked increase in the number of deaths for both Blacks and whites. But if you look carefully, you'll see the proportionate increase was higher among Blacks. Transplant patients likewise had an excess of deaths during the pandemic. And this is a recently published study from Portugal showing data similar to data in all other parts of the world. But here you can see that the number of excess deaths per month, that is the number of deaths that actually happened compared to the same month over the previous 5 years. The number of excess deaths was remarkable, and you can see at times like the end of 2020, beginning of 2021, with the Omicron onset, that the number of excess deaths went up as high as 60%. So the conclusions from those observations are these. First, CKD patients were the most vulnerable cohort to COVID-19 in the whole Medicare population. For the first time in the 50-year history of the ESRD program, the U.S. dialysis population experienced a decline in the number of patients on maintenance dialysis. Dialysis patient mortality was 37% higher in April of 2020 compared to the same calendar weeks of the previous years, and 16% higher in subsequent months, almost certainly the result of COVID deaths. Immunosuppressed transplant patients are particularly vulnerable to COVID-19 and its complications, and have a higher morbidity and mortality than non-transplanted patients with COVID-19. So let me turn then to what we've seen and know about disparities in care in those numbers that are disturbing and distressing. This is a table that shows the risk factors for contracting COVID-19 in Medicare-eligible patients with end-stage kidney disease on long-term dialysis. If you look, you'll see that of all of the risk factors, race was a very significant one, with Blacks having a 25% higher risk of contracting the disease. This is Blacks on dialysis. And if you look at the ethnicity, that Hispanics had a 68% higher risk of contracting COVID than non-Hispanic dialysis patients. You'll see those risk factors that we usually ascribe to acquiring COVID: heart disease, hypertension, chronic obstructive lung disease, diabetes. You'll see that they had an effect that was incredibly small compared to the effect of race or ethnicity. And while race and ethnicity are not biologically determined, obviously, the social factors that promote the difference in outcomes in race and ethnicity far outstripped these biologically determined factors. Second interesting thing to look at in terms of inequality is income inequality. The Gini index is an index in any given country for income inequality. And in the left-hand panel, you see that there is a clear correlation across the world when the inequality and income index was compared to COVID-19 excess mortality. In those countries where there was greater income inequality, there were a greater number of COVID-19 deaths. A second interesting study was done of 5,500 nationally representative U.S. adults and whether or not they were able to get needed health care during the pandemic. 1 out of 5 of these adults said that they were not getting the needed care that they wanted to have. Fair or poor self-reported physical health was significantly associated with being unable to get needed care despite chronic condition status. Uninsured adults were more likely not to get needed care. And so these authors concluded that delays in receiving needed medical care may exacerbate existing conditions and perpetuate existing health disparities among vulnerable populations. In this study, the COVID-19 pandemic was shown to increase the risk to persons with disabilities. These authors show that people with disabilities commonly experience 3 increased risks: the risk of contracting the disease, the risk of severe disease or death if they do contract it, and the risk of new or worsening health conditions as a result of contracting the disease. The authors say that national health emergency preparedness and planning may fail to consider the needs and priorities of persons with disability. And they say that opportunities uncovered in the COVID-19 pandemic included, number 1, data collection and analysis of health inequities was inadequate, and we need better ways of collecting data. Second, equitable access to innovations such as telehealth was not equally available to all, and those with disabilities were at a disadvantage. And finally, that inclusion in decision-making processes of people with disabilities is an important goal to deal with the next emergency or pandemic. So, lessons learned for patients with kidney disease, dialysis, and transplant. These patients are vulnerable, and they are a population requiring advanced planning and high priority. They're more likely to contract infections, suffer complications, and higher mortality. They have a complex support system. Think, for example, of what it takes to get dialysis equipment and supplies to each of the thousands of dialysis units around the country that are easily disrupted, requiring advanced planning to anticipate supply and personnel challenges. Life-saving care like vaccines and antivirals must be easily accessible to this population. And specific planning for transplant patients who are particularly vulnerable to infection and often sheltered in place for years, as we just heard from Ms. Williams. We need careful thinking about medical, social, and community planning for those vulnerable populations. In a paper that we published back in July, our group identified several important lessons and needs to learn for the next medical emergency. First, we need an accessible national patient database, one that is easily accessible in real time by investigators to understand what's happening and how to respond to it. Second, nephrology must have a seat at the planning table in hospitals and in government planning to help bring the knowledge of nephrology patient needs to the planning table. We need a federally funded proactive infrastructure to analyze data, perform studies, and make evidence-based recommendations. CDC did a wonderful job with what it had available to it. But if we went the next step to have a proactive infrastructure to analyze those data as it became available and to perform the necessary studies as soon as possible, it would make a big difference. Our supply chain must develop better capability for agility, and the national stockpile should include more dialysis supplies. Transplant patients are particularly vulnerable to infection and must be prioritized for urgent care. Dialysis and transplant patients must be included in clinical trials of vaccines, antivirals, and monoclonal antibodies in order to understand the risk and efficacy of these agents in this population. And finally, coordination and communication among dialysis providers and with government agencies must continue and must improve. Progress is possible, but not inevitable. We must create that progress. And finally, Nelson Mandela said, one of the challenges of our time is to reinstill in the consciousness of our people that sense of human solidarity, of being in the world for one another and because of and through others. This is something that really needs to guide where we're going.